Hey guys, welcome back in our YouTube channel, and today's our topic is local anesthesia blocks for mandibular nerve, that is mandibular nerve blocks. Before talking about mandibular nerve blocks, let's revise mandibular division of trigeminal nerve. I'm not going through the ophthalmic and maxillary division. I'm just now explaining mandibular division and after its mandibular nerve blocks. So as we all know, the division is the third division of the trigeminal nerve, which arises from the semilunar ganglia. After rising from semilunar ganglia, its sensory component arises from the semilunar ganglia, and after origin, it goes forward. And from the motor nucleus, motor part arises, and that motor part also run below the semilunar ganglia, and then the sensory part and the motor counterpart both run together side by side without joining, and they both pass through the foramen ovale, and after passing they join to form a single trunk. Then they give two main branches, first to the medial pterygoid that will also to supply the tensor tympani or tensor pallidolii, and second one is the nervous spinosum, which passes through the spinosum foramen to supply the cranial dura. Then it divides into two divisions, anterior division and posterior divisions. Anterior division supply the muscles of mastications, and posterior division sensory. Posterior division is mainly sensory, which supply the which give the branches inferior velar nerve, mental nerve, incisive nerve, and then it gives the long buccal nerve, lingual nerve. So mandibular nerve blocks are the blocks given to block the mandibular nerve or its branches. So these blocks are mainly are of two types. First, intraoral, given by the intraoral technique, and then given by the extraoral technique. In intraoral technique, we have classical inferior alveolar nerve block, and then which is given by the closed mouth technique. And then we have mandibular nerve block, which anesthetize the whole mandibular nerve. Then lingual nerve block, buccinator nerve block, mental nerve block, incisive nerve block. Then we have block of terminal branches, which we can say field block and local infiltration. By external techniques, we can give the mandibular nerve block, mental and incisive nerve block, and local infiltration. Coming to the classical inferior alveolar nerve block, which is given to anesthetize the inferior alveolar nerve and its subdivisions, mental nerve, incisive nerve, and occasionally lingual and buccinator nerve. The area anesthetized due to this block are the areas which are supplied by these nerves, like body of the mandible and inferior portion of the ramus, mandibular teeth, mucous membrane, and underlying tissue anterior to the mandibular first molar. To give the inferior velar nerve block, we have to follow some landmarks, anatomical landmarks, which are very important in giving this block. First of all, mucobuccal fold, then anterior border of the ramus, then external oblique ridge, after that retromolar triangle, and internal oblique ridge. Then pterygomandibular ligament. After that, buccal sucking pad and pterygomandibular space. And we know that this inferior velar nerve is in pterygomandibular space. So why we are giving this block? There are some indications. We are giving this block to provide analgesia for operating dentistry on all the mandibular teeth. As I want to do anything on the mandibular teeth, I have to give the inferior velar nerve block, otherwise the procedures are painful. Then if I want to do the surgical procedure on the mandibular teeth and supporting structures anterior to first molar, like if there is any fracture or trauma or any pathology, then I will give this block. This nerve anesthetize lingual nerve at the same time. When I am giving the inferior alveolar nerve block, this block also anesthetize the lingual nerve. So if I want to do surgical procedures on mandibular teeth and supporting structure posterior to second bicuspid, then I will give lingual nerve block as well as long buccal nerve block along with the inferior alveolar nerve block. And for the diagnostic and therapeutic purposes, also I can give the inferior alveolar nerve block. So inferior alveolar nerve block is used to give the analgesia on before doing procedure on mandibular region, especially mandibular teeth. So when we are giving this block, the needle passes through the mucosa, then thin plate of buccinator muscle, loose connective tissue, and variable amount of the fat. And when it reaches its position, that is final position, then it should be superior to inferior alveolar vessels, inferior alveolar nerve, insertion of internal pterygoid muscle, mylohyoid vessels, and mylohyoid nerve. But it should be anterior to deep part of the parotid gland, medial to the inner ramus of mandible, and lateral to the lingual nerve, internal pterygoid muscle, and sphenomandibular ligament. So how to give this block? If patient is in dental chair, its head should be positioned so that when mouth is open, body of mandible should be parallel to the floor. And then operator stands on right front side of patient. If we are going to give the right side inferior alveolar nerve block, then operator should stand to the right front side of the patient and his left index finger or thumb palpate the mucobuccal fold. The finger or thumb is then moved posteriorly until contact is made with the external oblique ridge on the anterior border of the mandible. Now you can see I am just giving a technique by following the anatomical landmark. First of all, mucobuccal fold I have palpated. Mucobuccal fold I have palpates. Then finger or my finger is moved posteriorly until the contact made with external oblique ridge on the anterior border of the ramus of mandible. When finger or thumb contacts the ramus of mandible, it is moved up and down. We have now ramus of mandible palpated. We should move up and down until greatest depth of anterior border of ramus is identified. This greatest depth area is corner notch, and this is in direct line with the mandibular sulcus. So this place is the height of the mandibular sulcus. So palpating finger is moved lingually across the retromolar triangle onto the internal oblique ridge. The finger or thumb still make in line with the cornoid notch and in contact with cornoid notch and in contact with the internal oblique ridge, then move to the buccal side, taking with buccal sucking pad, which give better exposure to internal oblique ridge, pterygomandibular raphe, and pterygotemporal depression. When palpating the intraoral landmarks with the thumb, we should place index finger extraorally behind the ramus of mandible, which hold the mandible between thumb and index finger. This is very useful. We can assess the anterior posterior width of the ramus. Then syringe of 1:5 by 8 inch 25 gauge needle is then inserted parallel to occlusion plane of the mandibular teeth from the opposite side of the mouth at the level bisecting the finger or thumbnail, penetrating the tissue of pterygotemporal depression, entering the pterygomandibular space, and we should determine the depth of the needle penetration by estimating when needle tip has been advanced half the distance between palpating thumb and index finger. During the insertion, patient is asked to keep mouth wide open. Then needle is penetrated into tissue until gently contracting bone on the internal surface of the ramus of the mandible. This should be in area of mandibular sulcus which funnel into mandibular foramen. So needle is then withdrawn about 1 mm and 1.8 ml solution is deposited slowly with the speed of 1 ml per minute. So needle is then withdrawn slowly, and when about half of its depth has been withdrawn, the remainder of the solution is injected in this area to anesthetize the lingual nerve. In some cases, deliberate injection of anesthetic solution to anesthetize the lingual nerve is unnecessary. Why? Because diffusion of initially injected solution will also anesthetize the lingual nerve. Now, I want to give the block on the left side. Then patient is placed in chair exactly same position as for the right side. The operator stand at the right and slightly toward the back of the patient. The left arm of the dentist is placed around the patient head so that landmarks may be palpated with the left index finger or thumb. Needle is inserted from the opposite side of the mouth at the level that bisects the nail of the finger, and tissue are penetrated by the same technique as I have followed for the right side. So one alternate technique is to stand to right and slightly toward the front of the patient. Landmarks then palpated with right index finger or thumb, and needle insertion or injection are made with the left hand, which is more feasible for the operator who are skilled at using the left hand. Then if all the subjective symptoms of anesthesia are present, then patient and if a patient says I'm still continue to experience the pain, then it is possible that it may be caused by the accessory innervation to the area, either by long buccal nerve or by cutaneous colli branches of the cervical plexus. So long buccal nerve should be anesthetized. Then we have to check then subjective symptoms, which we will check by the tingling and numbness of the lower lip. And when lingual nerve is affected, then tip of the tongue will be tingling and numbness will be there. So we will ask the patient about when I want to see or we want to see the subjective symptoms. And if for objective science, instrumentation will be necessary to demonstrate the absence of the pain sensation. We have closed mouth approach to mandibular nerve block, which anesthetize the inferior alveolar nerve and its subdivisions, mental, incisive, plus lingual and buccinator nerves, which are branches of the mandibular nerve. So whole mandibular nerve will be anesthetized, which anesthetize all the mandibular hard and soft tissue of the midline to the all the mandibular hard and soft tissue to the midline, including floor of mouth and anterior two-third of the tongue. And we have to follow the anatomic landmark for giving this mandibular nerve block by closed mouth approach. We have to follow first of all occlusion plane of occluding teeth, mucogingival junction of maxillary, molar teeth, and anterior quarter of ramus. It's indicated for analgesia for the operative or surgical procedure on the mandibular soft tissue and for the diagnostic and therapeutic purposes. And when needle inserted with closed mouth, it should be parallel to occlusion plane and positioned at the level of the mucogingival junction of maxillary molar. The needle penetrates mucosa just medial to ramus and inserted approximately 1:1/4 inch. When needle is in position, it should be superior to same inferior alveolar vessels, inferior alveolar nerve, insertion of interior pterygoid muscle, lingual nerve, buccinator nerve, mylohyoid muscle, mylohyoid nerve, and anterior to the T part of the parotid gland, medial to the inner surface of the ramus, lateral to the internal pterygoid muscle, and spinomandibular ligaments. So now we have to give this block. Then we follow the technique. We allow the patient or ask the patient to sit comfortably in the dental chair. The operator stands to the patient's right side and slightly to front. patient is instructed to occlude the teeth. And this is the closed mouth approach. So we instruct the patient to occlude the teeth. The operator retract the patient's lip, exposing the maxillary and mandibular teeth on the right side. Then syringe 1:5 by 8 inch, 25 gauge needle attached, is aligned parallel to occlusion plane and sagittal plane, but positioned at the level of the mucogingival junction of the maxillary molar. The needle penetrates the mucosa just medial to the ramus and inserted 1:1 by 2 inch. Following negative aspiration, contact of dental cartridges slowly deposited. So successful anesthesia will be determined by the instrumentation of the inferior alveolar nerve and its subdivisions like mental and incisive nerve plus buccinator and lingual nerves. Care should be taken to ensure the needle is inserted as closely as possible to the medial surface of the ramus. Allowing the needle to be advanced too far medially will result in deposition of solution on the medial side of the pterygomandibular space and sphenomandibular ligament, which result in the inadequate anesthesia and unsuccessful nerve block. So, although closed mouth technique for the curing anesthesia of inferior alveolar nerve, buccinator, and lingual nerve is described by Akinowski in 1977, but it gained favor. Alternative to classic inferior alveolar nerve block for several reasons. First, landmarks are easily identified. Then technique is simple to master. Second, 3 major nerves innervating the mandible may be anesthetized with 1 needle only. And third, apprehensive patient feel less threatened psychologically when anesthesia is administered with this technique. So this technique relies on the minimum bony landmarks for its execution. So one is likely to be less successful with this technique. So depth of needle insertion in particular is a nebulous factor and often result in failure. If I have told you before, if we go too medially, unsuccessful anesthesia or improper angulation in superior direction may result in partial or complete anesthesia of the maxilla. So improper medial angulation should be prevented. Then in 1973, Goget described a true mandibular nerve or trigeminal nerve, trigeminal third division block by means of intraoral approach using intraoral and extraoral both landmarks to deposit the anesthetic solution at the neck of the condyle. A single anesthetic injection which provides hard and soft tissue anesthesia of the mandible to the midline, and it anesthetizes the mandibular nerve and its subdivision including inferior alveolar, lingual, buccinator, incisive, mental, mylohyoid and auricular temporal nerves, which is anesthetize the mandibular hard and soft tissue to the midline including floor of mouth, anterior two-thirds of tongue, lingual soft tissue and periosteum, skin over the zygoma, posterior portion of the cheek, temporal region and portion of the external ear. We will follow both the landmarks, extraoral as well as intraoral. So first landmark is anterior border of the ramus, then tendon of temporalis muscle, then corner of mouth, then intertracheal notch of the ear and then external ear. This block is indicated whenever we need operative or surgical procedure on the mandibular teeth, or when buccal and labial soft tissue anesthesia from the third molar to midline is necessary, or when lingual soft tissue anesthesia is necessary for diagnostic and therapeutic purposes, of course. And then when patient's mouth is wide open, often the needle is inserted at the point lateral to pterygomandibular depression but medial to temporal tendon on a plane from anterior of mouth to intertracheal notch. So whenever needle is in the final position, it should be just inferior to condyle and itself and inferior to attachment of the lateral pterygoid muscle. So for this Goget technique, patient should be placed in supine position. Although semi-recumbent position may also be used, operator is positioned to the right and slightly in front of the patient. Patient keep mouth wide open, remain in that position until injection is completed. This position moves the condyle anteriorly and facilitate the injection. Then imaginary line is drawn from the corner of mouth to intertracheal notch of the ear. The anterior border of ramus is palpated and tendon of the temporalis muscle is identified. Operator visually align the intraoral extraoral landmarks and needle is introduced through the mucosa just medial to temporal tendon and directed toward the targeted area on the line extended from the corner of mouth to intertracheal notch. The degree of divergence of the external ear to head is used as a guide to lateral flare of the ramus. So needle insertion should be parallel to degree of flare of the ear. The needle should be advanced until fovea region of the condyle neck is contacted. Depth of insertion should not exceed 25 to 27 mm. Then if bone contact is not established, needle should be withdrawn slightly and redirected after checking the landmarks. So entire contact of the cartridge should be injected only after establishing proper needle placement, that is bone contact. And after operator withdraw the needle, patient is to keep mouth open 20 to 30 seconds to allow adequate bathing of the nerve trunk, which has been straightened by the opening the mouth. Because large diameter of nerve trunk and distance from the injection site about 1 centimeter, onset of anesthesia will occur 5 to 7 minutes. So wave-like pattern of anesthesia start in ramus and progress steadily toward forward to include molars, premolars, and anterior teeth in the sequence. Adequacy of anesthesia may be demonstrated by tingling and numbness in the area innervated by the mandibular nerve and its subdivisions, as well as by the absence of pain on the instrumentation. This approach gained more popularity as compared to conventional inferior alveolar nerve block. Main advantage lies its ability to produce anesthesia of entire distribution of mandibular nerve with single needle penetration. But this technique relies on soft tissue landmark that vary from patient to patient. So distorted, be easily distorted during injection or misinterpreted by the operator. Success rate is likely to less than satisfactory. Phobia is the bony landmark that must be identified and quite small and difficult to locate. So this technique is useful, has merit, great degree of success, reliability achieved by the dentist, mastered and more traditional techniques which rely almost entirely on predictable bony landmarks. Now comes to the lingual nerve block. Lingual nerve block is used to anesthetize the lingual nerve, that is the branch of mandibular nerve. So, due to this nerve anesthesia, anterior two-thirds of tongue and floor of oral cavity, mucosa and mucoperiosteum of lingual side of mandible got anesthetized. And landmark follow for these nerve block are the same as we follow for the inferior alveolar nerve block. And this nerve block is indicated for the surgical procedure on the anterior two-thirds of tongue, floor of the oral cavity, mucous membrane on the lingual side of the mandible. So we follow that technique in inferior alveolar nerve block, that is same for the lingual nerve block. So for the symptoms of anesthesia, the tingling and numbness on anterior two-thirds of the tongue will be there, and for objective type symptom we need instrumentation to demonstrate the absence of the pain sensation. Then come to long buccal block, that is the vaccinator nerve block, which anesthetizes the vaccinator nerve branch of the mandibular nerve, which anesthetizes the buccal mucous membrane and mucous periosteum of the mandibular molar area. For this block, we follow anatomical landmark. Only two landmarks will be followed, that is the external oblique crease and retromolar triangle. And this block is indicated for the surgery on the mandibular buccal mucosa and to supplement the inferior alveolar nerve block. So we have technique for this block. 1 each 25 gauge needle is inserted into buccal mucosa just distal to third molar, and 0.25 to 0.5 ml of solution is deposited in this area. An alternative technique is to insert the needle and deposit the solution directly into the retromolar triangle. To check the effectiveness of this block, we will check the objective signs. No subjective symptom will be there. So, objective signs checked by the instrumentation. Then comes to the mental nerve block, which is used to block the mental nerve branch of the inferior alveolar nerve, which anesthetizes the lower lip and mucous membrane in the mucolabial fold anterior to the mental foramen. And anatomical landmark followed for this block are the mandibular bicuspid, as the mandibular foramen, mental foramen usually lie at the apex and just anterior to the second bicuspid groove. So this block is indicated for the surgery on the lower lip or mucous membrane in the mucolabial fold anterior to mental foramen when or for some reason the inferior alveolar nerve block is not indicated. So this block is given in the apex of the bicuspid teeth. So 1-inch 25 gauge needle should be inserted into the mucobuccal fold after the cheek has been pulled to the buccal side. Tissue is penetrated until the periosteum of mandible is gently contracted slightly anterior to apex of the second bicuspid. Then solution of 0.5 to 1 ml is slowly deposited in this area. Then check the tingling and numbness on the lower lip on the injected side to check the subjective symptoms. Incisive nerve block. This nerve block will anesthetize the incisive nerve and mental nerve, which anesthetize the mandible and overlying labial structures anterior to the mental foramen. It will anesthetize the bicuspid because spits and incisors on the pectoral side, and it also anesthetizes lower lip on the pectoral side. Landmark are the same as that for the mental nerve block, and this block is indicated for the anesthesia of mandible and labial mandibular structure. Then it's indicated for the anesthesia anterior to the mental foramen and lower lip when or for some reason inferior alveolar nerve block is contraindicated or unnecessary. Technique is also same as that for the mental nerve block, except the needle point should penetrate into the mental foramen to anesthetize the incisive nerve adequately. Mental nerve will automatically anesthetize at the same time. To check if this block is effective or not, we will check the subjective symptom. Patient will experience numbness and tingling of the lower lip. And for objective signs, we will do the instrumentation. Then comes to the block of terminal branches, which will anesthetize the terminal branches within the mandible and then which anesthetize all the areas innervated by these branches. So landmarks will depend on the area to be anesthetized, like individual teeth, their root areas, and periosteum of the bone. So these terminal branches block needed to secure the anesthesia is as a rule not too successful in the mandible. However, when for some reason this technique is to be used, it's more successful for the 6 anterior teeth. So, the paraperiosteal or intraosseous techniques, these are the commonly two techniques used to block the terminal branches. So, it's just like a field block. So, as there are no subjective symptoms after this block, local infiltration will anesthetize the free nerve endings in the infiltrated area, which anesthetize the mucous membrane and mucoperiosteum in the infiltrated areas. So for this local infiltration, no anatomical landmarks are used. Why? Because the solution is infiltrated into the required areas. So it's indicated for anesthesia of restricted area of mucous membrane for limited soft tissue injury or soft tissue surgery or subsequent insertion of the other needle. So for the local infiltration in mandibular area, 1-inch 25 gauge needle is inserted into the beneath the mucous membrane into the underlying tissue, and the area is infiltrated with the anesthetic solution. Then more than one needle insertion may be necessary depending on the area anesthetized. The solution should be injected slowly and in minimum volume. So no subjective symptoms are there. The instrumentation will determine the presence of adequate anesthesia. Then we have extraoral techniques in which we have mandibular nerve blocks, mental and incisive nerve block, and local infiltration. In the extraoral technique, for mandibular nerve block, the nerve anesthesia are mostly mandibular nerve and its subdivisions, then inferior velar nerve, buccinator nerve, lingual nerve, mental nerve, or incisive nerve, which will anesthetize all those areas innervated by the mandibular nerve and their subdivisions like temporal region, auricles of ear, external auditory meters, temporomandibular joint, salivary gland, anterior two-thirds of tongue, floor of mouth, mandible, lower teeth, gingiva and buccal mucosa, lower portion of face except at the angle of the jaw. So landmark are same as for the extraoral block for maxillary nerve. So indication for this nerve block is indicated when it is desirable to anesthetize the entire mandibular nerve and its subdivision with one needle insertion and minimum anesthetic solution, or when infection or trauma make anesthesia of nerve subdivisions difficult or impossible, or it can also indicate it for diagnostic and therapeutic purposes. So technique followed for mandibular nerve block is essentially the same as that used for block of maxillary nerve, with the exception that a marker is placed on the needle at the major distance of 5 cm. After the needle contacts the lateral pterygoid plate, it is withdrawn exactly as is in the maxillary block. However, when reinserted, needle is directed upward and slightly posteriorly, so that needle will pass posterior to lateral pterygoid plates. Needle should not be introduced into the depth greater than measured 5 cm. So structures through which needle passes and structure adjacent to needle when it is in contact with lateral pterygoid plate, they are same as for the maxillary nerve block. So here we will check the subjective symptoms. The patient will tell about the tingling and numbness of the lower lip and anterior two-thirds of the tongue. Then we will check the objective sign by asking the patient to open the mandible and tapping the jaw shut with shut. Then difference in the feeling of the lower teeth and floor of the mouth will be noted. Instrumentation will also determine or demonstrate the presence of anesthesia. Then we have mental or incisive nerve block, which anesthetize the mental and incisive nerve and which anesthetize area of lower lip, mandible and overlying buccal labial structures anterior to mental foramen or mandibular teeth anterior to mental foramen. And anterior landmarks are followed are the bicuspid teeth, lower edge of the body of the mandible, supraorbital notch, infraorbital notch, and pupil of eye. And this block is indicative when anesthesia of mandibular teeth and labial and buccal supporting structure anterior to the mental foramen or lower lip is desired, and block of inferior velar nerve block is contraindicatory. So for the technique for mental and incisive nerve block extraordinarily, patient should close the mouth in normal position and look straight forward. Then supraorbital notch and infraorbital notch are palpated and located. With patient looking straight forward, imaginary line drawn from the supraorbital notch or foramen through the pupil of the eye, infraorbital notch or foramen will, and continue downward pass through the mental foramen. Midway point between the lower border of mandible and gingival margin is estimated and marked on the imaginary line. This should locate the mental foramen. After the skin wheel is raised, at this point, 2-inch 22 gauge needle is introduced in a slightly anterior and downward direction. With gentle probing, the mental foramen should be located and entered. 1 millimeter of the anesthetic solution should be adequate to produce satisfactory anesthesia. When mental nerve block by means of extraoral approach is performed, needle pass through the skin, subcutaneous tissue, and triangularis muscle. Then we should check for the subjective symptoms by asking the patient for tingling and numbness of the lower lip of the side injected, and then do the instrumentation which further demonstrate the presence of anesthesia. In the last, come to the local infiltration, which anesthetize the free nerve endings and which anesthetize the area, immediate area of infiltration. No specific landmarks needed for this, and this is indicative for purpose of incision and drainage in the mandibular area and insertion of pins. And for this technique, one each 25 gauge needle will be inserted subcutaneously and skin wheel is raised, and in subsequent injection dentist insert needle through the skin wheel fanning out into the desired area, which will produce the sufficient anesthesia of the localized superficial area. In case of infection, subcutaneous tissue only should be anesthetized to permit the incision and drainage. So no valid subjective symptoms will be there, and for objective systems, we have to do instrumentation, which is necessary to demonstrate absence of the pain sensation. So this is all about the mandibular nerve blocks. Thank you. Have a nice day and kindly subscribe my channel.